Neufeld. We're going to wait just one more minute for a couple more people to join, and then we'll be getting started here momentarily. All right, welcome everybody. My name is Jonathan Neufeld. I am the director of the Great Plains Telehealth Resource Center and located in Minneapolis, Minnesota. And this is the monthly National Resource Center webinar for May 17th, 2018. We're going to be talking about telemental health today. These webinars, just to give you a little background, are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. They're presented on the third Thursday of every month. The telehealth resource centers are located throughout the country. There are 12 regional telehealth resource centers and 2 national resource centers focused on policy and technology. And these resource centers are supported, funded by the Health Resources and Services Administration through the Office for the Advancement of Telehealth. We provide a range of technical assistance, individualized consulting, and educational services around telehealth. And most of what we do, almost everything we do, is free of charge. So please do contact us and let us know what we can do to help with your programs. A couple of tips before we get started. Your phones your mics are muted. Your channels of you coming into the webinar are muted. Use the Q&A function. There's a little Q&A window. If you may have to put your mouse pointer into the window to get to see the controls pop up, but you can use the Q&A function on that Zoom platform, our video platform, to ask questions. And I will look at those questions at the end of the webinar. Ray Dazan, our national coordinator, is also on the call, and he'll be watching them throughout the webinar. So if something comes up, Ray can chime in, or let me know that there's a question that needs to be addressed right away. We're also recording this webinar, so at the end, it'll be placed on our YouTube channel with the link there on the page, and you can go back and review it at your leisure. Today's webinar is hosted by the Great Plains Telehealth Resource and Assistance Center, that's GPTRAC, and as I said, I'm the director. We're going to talk about telebehavioral health models and strategies for rural hospitals and clinics. And away we go. Here's an outline. I already gave you an introduction to GPTRAC and to the Telehealth Resource Centers, so I won't do that again. I'm going to start with some conceptual prerequisites. These are some points that we, the resource centers, make a lot just to sort of put a frame around telehealth, because a lot of people mean a lot of different things by telehealth these days, and we want to be inclusive and mean all of those things, but there's times when we need specific, and so I'll put a little framework for us to think about telehealth and telemental health. Then I'll talk a little about reimbursement and sustainability and some various program models, and we should have some time at the end for Q&A. So on to some background. We have come to talk about domains of telehealth as a way of differentiating different types, and I won't spend a whole lot of time on this, but it is important to recognize that telehealth means different things to different people. The first and maybe the primary or the grand progenitor of telehealth is hospital and specialty care. And we started out there telehealth started out there. And it is still a lot of telehealth. There is still a lot of telehealth that gets done that way. And this assumes that specialists are located at a hub site somewhere and they're delivering telehealth services or specialty services via telehealth. Telehealth is not a service itself, but we'll talk about that in a bit. But is delivering specialty services out to rural areas. The flip side of that, which is almost as old, is the idea of using telehealth to provide integrated primary care. In some ways, it's just the other side of the window, the other side of the screen, but with recent emphases on enhanced primary care or patient-centered medical home, CPC plus, all of these all this focus on primary care that was really brought to a head and was pushed pretty strongly by the Affordable Care Act. Telehealth has been used to develop, to support and to provide enhanced primary care services. So on the one hand, it's just the same thing of bringing specialty services into the primary care setting, but it doesn't necessarily have to be rural, and it's really looking at it from the other perspective, from the other side, if you will. There's another whole domain that has to do with remote monitoring and more or less asynchronous connectivity between providers and patients. And that remote monitoring world is usually deployed to manage transitions and help with health maintenance and improve outcomes after discharge. And it's a different application of the whole technology skill set. It sometimes will involve live video, but a lot of times it's physiological data being sent back and forth that's being used in those applications. And then direct-to-consumer services is probably the youngest domain of telehealth, and we separate it out because even though it may be using live audio, maybe using live video, maybe using data exchange of various kinds, it may be using the same sorts of technologies, it really is a different domain in the sense that it is contracted differently and provided differently. The administrative and reimbursement domain around it is different, and the value drivers in that domain are different. And that's true. The value drivers, the quality, the real value that telehealth services within each of these domains brings is fundamentally and qualitatively different. And so that's why we can't just talk about one thing, one telehealth domain, but there are various dimensions of it that we need to take account of. The other thing that's not on this slide and that kind of moves a bit across all of them and is in some ways its own fifth orthogonal different dimension is mHealth, mobile health. And mHealth or mobile health is usually used to refer to the platform through which it's delivered, that platform being cell phones. It could be tablets, it could be other very lightweight small devices, but it is a mechanism of delivery of services through the whole app ecosystem, apps that run on tablets and cell phones, etc. So that's the world of mHealth, and those are the domains of telehealth. All right. So what I've kind of implied, and what I hope to make clearer here at the beginning here, is that telemedicine is a delivery mechanism. It's not a service. You don't receive telehealth services, although we sometimes say that. What you're receiving is healthcare services, whether it's a primary care interaction, an urgent care interaction, a mental health therapy session, a medication management session, an evaluation of your blood glucose, or whatever it is. You're receiving a healthcare service. Telemedicine is the mechanism, the channel, but it's not the service. The service is whatever you would receive if you were in person on site with the provider at the time. So to provide telehealth services, providers don't need any new certification or credentials per se. Sometimes they need to be re-credentialed at a new facility because they're now going to be providing services at a new facility, but it doesn't mean I need to have a different set of credentials to provide at the facility. I'm still doing the same scope of care that my license provides as a healthcare provider, but now I'm delivering it using the channel of telehealth, possibly at a new location. And by the same token, all the regulations that apply to healthcare services generally, including credentialing and licensure and all of that, also apply to telehealth equally. So there's no difference there. I sometimes use the analogy of an Army field hospital. You still need to keep wounds sterile and disinfected, but it's a little different question in an Army field hospital than it is in the big university medical center OR. Okay, it's the same. We're doing the same thing. We're doing a surgery and we're trying to keep the wound clean, but it's a little different. The methods by which we do that are slightly different depending on the location. And telehealth is the same way. We're providing the same clinical service, but when we're doing it over telehealth, sometimes there are a few things that need to change just because of the nature of the domain that we're working in. So if you want to get a framework around the regulatory environment for telehealth, and I do this just to help people kind of think through telehealth for themselves, we talk about federal regulations and state regulations, but in reality, the only regulations, the only laws that apply to telehealth at the federal level are privacy and healthcare regulations generally, what we've just been talking about. So the Stark Law or the anti-kickback laws, these apply to healthcare generally. HIPAA laws about security, these apply to healthcare generally. So there's nothing specific to telemedicine at the federal level. It's just healthcare. But possibly you could say the Ryan-Haight Act has a specific federal regulation around telemedicine, and it's about actually the prescribing of controlled substances. And telemedicine only gets mentioned as an exception within the Ryan-Haight Act. Unfortunately, an exception that has not yet been fully worked out. There's some movement to work out that exception and to define it more specifically. But at this point, that's really all there is at the federal level about telemedicine. Now, people talk all the time about Medicare regulations around telemedicine. And what Medicare actually does is it sets conditions of payment. Now, that I may be splitting hairs there, but Medicare doesn't tell you what you can and can't do over telemedicine. What it tells you is what you will and won't get paid for by Medicare. So that's a federal regulation. What Medicare will pay for in telemedicine is a federal is set out in federal guidelines. You can provide a whole range of services to Medicare beneficiaries. It's just that Medicare is not going to pay you for all of them. It's only going to pay you for the things that it specifies. Now, by the same token, you can talk about the state level and state regulations, and really, state regulations can be more extensive, but there also may be very little at the state level in terms of actual regulations. Sometimes state legislatures will say Medicaid needs to cover this or Medicaid needs to cover that, and so they'll pass laws that influence or drive or guide Medicaid per se. But but those laws are usually about what Medicaid will pay for or not pay for. The rules that tell you what you can and can't do are all within the licensing board. Are all handled by the licensing boards, and usually the legislature just empowers the licensing boards to set regulations, and then the licensing boards set those regulations. So what you can do it as a physician, what you can do it as a psychologist or a social worker or a nurse or whatever, are set by your licensing boards. So that's can and can't do. Now, will and won't get paid, that's again at the state level, a slightly different level of regulation, if you will. And certainly Medicaid varies from state to state, and commercial payers will have regulations set upon them at the state level as well, like parity laws are the perfect example. Does a commercial plan have to cover telemedicine the same way as it covers in-person care? That law is set at the state level. So again, they're not going to tell you what you can and can't provide. Only the licensing boards can do that. But they can tell you what they will and won't pay for, and that ends up being a fairly effective way of limiting or restricting care. Now, the other thing that we have to recognize as we're talking about telehealth that complicates our discussions a little bit, before we get into the models of providing mental health care, is that, what a surprise, newsflash, healthcare is changing. It's changing rapidly, and certainly that's not new. Healthcare has been changing rapidly since since society has been changing rapidly. Healthcare just moves fast. But also the technologies by which healthcare is delivered are moving fast. We're always hearing about new stuff that's being developed and is now being deployed in the domain of healthcare. And by the same token, telemedicine and the technologies that enable telemedicine change fast. Now, historically, telemedicine has since the beginning, and by beginning, I mean the beginning of regulations, which is in the mid-90s with the Medicare regulations. There are some state laws that predate that. But when Medicare first, at a federal level, set out what telemedicine was, it was restricted to live video, live interactive video, and almost every telemedicine rule since then has restricted its coverage, its scope to live video. Now, there is also asynchronous, so live video is synchronous. In other words, the two sides are operating at the same time. Asynchronous is usually also considered as a form of telemedicine. It's the type when the two sides are not operating at the same time. This is store and forward. This is when you post an image or post some results that then a physician can review, later in the day, or they can get a bunch of cases and they can review them really quickly and make recommendations. And it's kind of an email or messaging system for providing specific findings or diagnostic evaluations. Radiology is a perfect example. You take an X-ray, it gets posted to a system, and then at some point in the next 24 or 48 hours, a radiologist sits down and they start looking at films, and they say, oh, that looks like a broken bone. Oh, that looks like this. That looks like that. And that's how store and forward asynchronous telemedicine works. Almost always telephone, fax, and email are excluded. In almost every telemedicine law, telephone, fax, and email are just kind of ruled out. Now, the reason I bring that up and talk about it changing is that with the advent of population health, and by population health, you probably all know what I mean, but the idea is some services are not billable encounters anymore. For example, chronic care management codes. In the traditional system, doctor sits down with a patient for the next 5 to 15 to 20 to 200 minutes. We work together, and then you bill that. That's an encounter that gets billed with a code and gets paid for that encounter. But with the advent of population health, we're getting more and more complex ways of delivering care that may include a phone call between visits, or it may include a visit by an unlicensed provider, or it may include, data review for a device that is measuring your blood pressure. It could include the use of an app or an exchange of text messages, or all sorts of things that aren't individually billable, but nevertheless may fall within the category of a billable service that's billable on a monthly basis or on some sort of time basis. There are also quality measures and quality-based that are based on, at the end of the year, such and such will have happened, will have shown a certain amount of improvement or a certain amount of quality, however it's defined. And so then there might be a bunch of things that a healthcare system or a provider does to boost their quality score that aren't individually billed for, but then at the end of the year, they show that quality is high and they get a payment for that. So as healthcare changes, we are starting to use telecommunications technologies in ways that are broader than just live two-way video. And by the same token, or in a somewhat similar way, because healthcare providers we have such chronic shortages of actual healthcare providers, we're starting to deploy services that are what we would call force multipliers, where a specialist, the ECHO model is a perfect example, where a specialist sits down with a group of primary care doctors once a month, and they do case reviews. And basically, each of the primary care doctors is working to become a sort of a mini specialist within a domain. So access to mental health, for example, may be scarce. And so instead of sending patients to the mental health provider, each of those primary care docs sees mental health patients and then consults with a specialist. And in that way, you can use the time of the specialist much more efficiently. They're not seeing every patient, but they're talking to doctors who are talking to patients, or some other mid-level. There are other sorts of force multiplier types of interventions. All right, so all of that said, we want to talk about some models in mental health care. How are telehealth services being used in rural areas to provide health care? Well, when we're talking about a telehealth service, we usually, I break it down into 4 kind of components. And the first is, of course, the most important. What actually are the services that you're providing? And that needs to be defined. Sometimes that's a no-brainer. Sometimes that is the issue that makes or breaks the service. So it's important to recognize that. We also have to have some way of sustaining the service once we're delivering it. We need to have some sort of policies and procedures in place so that we can operationalize the service. And then, of course, it's all going to ride on technology. And the reason I put them in that order is because the fundamental question is the service definition, and second is sustainability. After that, we can talk about operations and technology. We only put it in that order because for a long time it used to be people would make the decisions backwards. They'd find a piece of technology, they think that's great, that's going to solve my problem, buy a piece of technology, and then find that you can't develop a telemedicine services based on a piece of technology. It's just something the telehealth resource centers have learned, and we try and underscore that whenever we can. Okay, so the first model, pretty straightforward, direct care. The remote specialist sees the patient in a rural area. There's a originating site facility fee that you can bill for the patient at the clinic, for presenting the patient and for nurse time and keeping the lights on and all of that. The specialist who's providing the care can bill the patient's insurance, third party, or the whatever, whoever the payer is can bill according to the coverage. Okay, so it's just healthcare at a distance, direct care. A couple of things to recognize: the service legally occurs at the patient's location, so that provider has to be credentialed at that location. They have to be licensed at that location. It has to be legal and ethical for them to practice to do this thing at that place, because that's where the service is happening. The provider has the right to bill for that service. They can also turn over the billing to the local clinic. The CPT is the same as if they were in person. Actually, these slides are a little old. I'm sorry. The modifier GT is now 95 in some places. Medicare wants 95 instead of GT. And some states are just dropping the modifier altogether. Minnesota has dropped the modifier altogether, and is instead relying on the next point, a place of service code. So even though the patient is sitting at a certain location in a clinic, the physical location of the patient, the place where telemedicine is said to occur, the service code 2, which kind of means in the telemedicine ether, it occurs over telemedicine. So that signals compliance and regulators that this is a telemedicine service, even though the patient is at a certain location, and that location may have to be rural and all of that. The telemedicine service is happening over telemedicine. So that's how we designate that service. But the thing of it is, most telehealth, and we've learned this over the years, most telehealth is not that. It doesn't occur according to that model. Most telehealth is not structured according to that model, but often, and probably the number one implementation or model for telehealth, is that internal resources to a large health system are redeployed. So, and it doesn't even have to be a large health system. It might be a community mental health center that has 3 or 4 locations, but all the psychiatrists are sitting at one, and so they want them to see patients at the others. Well, for years and years, they would drive to the other locations and see patients. So now this CMHC says, you know what, we're going to implement telehealth. We're going to let our clinicians stay where they are, and we're going to see patients by video at all the other sites. Work time can increase efficiency, can do a lot of great things, but it is not telemedicine as Medicare conceptualizes it. Now, most of the time, most payers don't have any problem with this, but it is different, and I'll talk a little about that in a sec. Another way that telehealth is used is it generates some sort of internal value, like remote monitoring being used to reduce readmissions. So the value of the system is in reducing penalties, or reducing travel costs, or reducing some other thing that we don't want to have happen. And in that way, it generates value. So it's not just reimbursement coming in, and it's not some remote entity that's billing clinical code, but we're generating value in some other way. The other thing is that most external resources, and not all, but most of the times when external resources are brought in, like external specialists are brought in, the most common way of engaging them is through contracts, not hiring them, and not, if they're not already on staff and you don't hire them, or you don't let them bill their own services, which is how Medicare sort of envisions this all happening. If you instead contract with that external, psychiatry is a perfect example. You're contracting with an external psychiatrist or an external telepsychiatry company, and then that provider turns over their billing, and then the local clinic has the right to bill for those services, which again, very common, but is not the way Medicare conceptualizes it. So it's different. There are a number of reasons, and I don't need to go into those. Basically, they're more sustainable business models, and they allow more flexibility. And in short, they just make more sense, but they can lead to issues. So, and this is just a picture of the same thing that I just talked about. Several states explicitly allow this type of arrangement at FQHCs and RHCs, which tend to be a kind of a hot button issue here. But the patient is sitting at the HC, the provider is contacted at the remote site, and then the local FQHC bills its rate for that service. In Indiana, there's actually a specific term for this. It's called telecommuting. The provider telecommutes to the clinic and provides services, and the clinic treats it as if it is an on-site service provided by a contracted clinician on-site. It's exactly as if the provider were there, and it's billed the same way. Illinois also promotes the same sort of model. They have different terms for it. California promotes this model. This image is actually from California. And there are a number of other states that promote the same thing. Minnesota, I know, does the same, allows the same as well. The sticking point, and it doesn't matter whether you're contracting with a large medical center or, in this case, a telepsychiatry company. Okay, there will probably be some questions about this because there is a sticking point in this arrangement, and that is that FQHCs and RHCs, those programs are federal programs, and CMS, when they provide in the guidelines that they provide to FQHCs and RHCs, they say that an FQHC or an RHC cannot serve as a distant site in telemedicine, which what they mean by that is they can't bill the provider end of a telemedicine encounter, assuming that it has two ends. Well, as we just said, most telemedicine doesn't have two ends anymore. There's usually just one organization with a contractor, or one organization with its own internal resources being redeployed. And so that's what complicates this question. We can dig into it further if you want in the Q&A, but I'm going to leave that there, and I will suffice to say that that there is no, I hate to say this, there is no one right way to do this, but many organizations and many FQHCs and RHCs, many clinics bill according to this model and are successful doing it. And you can get various opinions from various experts within CMS, within the MACs, within any kind of payer experts. Telemedicine community has pretty much reached a consensus that this is the appropriate way to organize and build this. But CMS still has that rule from 1996 that we're working on. So I'm going to leave that there and move on to some of the other models. Do not let this be something that keeps you as a clinic from deploying telehealth services, specifically telemental health services, but do be aware of some of the nuances involved. So in general, before I go into a couple of other models, I want to talk about in general some of the challenges that organizations face. Probably the key one, and this is still an issue, and it catches people off guard every single time, well, not every time, but many times, and that is, yeah, I'm talking about the second one, but this is the key one. Value generation and monetization. Providing services is a no-brainer at one level. You got to provide services. There's a huge need. But how are you going to sustain that program? Is there direct reimbursement? Is there some sort of value generation that is monetizable in such a way, even if it's not monetizable, can you generate value in a way that sustains the program? So that's the first. The second one that does catch people off guard, this is the one I meant to start with, but the one that catches people off guard is generating internal interest in utilization. Providers, for the most, still tend to be reluctant to start to use a telemedicine service, even though they've been, for example, wanting mental health services. It's still more programs than you would expect have challenges getting those internal referrals to be generated to start using the new telebehavioral health service. So don't be surprised by that, and don't just expect it. If you build it, they will come. It's become a cliche in the telemedicine world. They won't come unless you train them to start using that. And I think there are a number of reasons for that. But one of them is that behaviors are just hard to change. And people have developed workarounds, and they've developed some very good workarounds for years and years. If now all of a sudden a new telebehavioral health service is put in place, it can take some time for providers to get that into their routine. They work so fast, and they see so many patients, to stop and say, whoa, I've got a new mental health person. Oh, okay, I'm going to send you that way instead of doing this thing that I normally do. That can take some time. So be aware of that, and work on champions, work on processes, work on getting screening and diversion policies or practices at the support staff level, so that the doctor isn't the only one who has to remember in the middle of an appointment, oh yeah, I want to refer you to this place instead of that place now. Get that at the staff level so that they can catch those referrals and recommend them to the physicians so they can make them. And then third, technical decisions or policy decisions, or the program is sort of conceptualized and implemented virtually before it's ever actually run, and then those policies are too inflexible down the road. A lot of telemedicine programs are sort of, iterative. It's not working this way, we're going to tweak this, we're going to move this, we're going to change that a little bit, and you really need to be ready to iterate and to make little changes as you get new information, as your vision clarifies for what exactly you need to get done. And the point I want to make with this whole page, you've already read the words, is that these are general management issues. These are issues in healthcare generally. These are not specific to telehealth. Telehealth did not invent these issues. These are issues that you already have. Telehealth is not going to magically avoid them. But if you have them and haven't thought through them, telehealth is going to bring them out. These issues will come up in the new telehealth program, like they'll come up in any new program that hasn't been adequately defined and monetized and all of those various things. All right. So direct services we talked about. I want to talk a little about chronic care and collaborative care. I want to talk a little bit about echo groups, sharing networks, resource sharing networks or communication networks, which are kind of a new thing, and then emergency evaluations and placement. These are some models that we have seen various examples of over the years and are pretty interesting. So this is kind of review. I just kind of went over this specialty care. If you have existing specialty service volume and you're trying to move it out to a larger area or basically support an outreach clinic, then you can provide specialty care through an outreach clinic and avoid the travel time. Okay, that's one model, and it's kind of that direct service model. It involves credentialing at the remote site and coordinating of resources. Sustainability at the rural site is often a challenge in this sort of a model. Okay, in that direct services model. So rather, what you have instead are often the service is conceptualized and hosted from the other side, from the primary care side or from the remote clinic side. And this is that model I talked about where you might contract with a specialist, and you might contract with one type of specialist here and another type there. It's not that they all have to come from the same university medical center or the same multi-specialty group or whatever. You might have a local mental health practitioner, LCSW, or somebody that you contract, and then you get psychiatry care from some organization in another state that does telepsychiatry. You might get endocrinology from a local hospital. You might need to go to the big city for neurology, whatever. You can mix and match these. And those services can be turned over to the clinic for billing, and the clinic, by and large, will have access to bill all of the codes that the specialist would normally bill. Now, every now and then, there are some esoteric code that Medicare or Medicaid or a commercial payer won't cover over telemedicine. Usually Medicare is the issue. You rarely have issues with commercial payers. They're either going to cover telemedicine or not, but sometimes it gets a little more subtle than that, or sophisticated, specific than that. But Medicare is the one that often has challenges, primarily the rural originating site. But in general, the bread and butter codes of most healthcare is covered by telemedicine by most payers that are on board with covering telemedicine. You usually don't see, weird sort of benefit carve-outs and strange kind of coverage. Usually they either cover telemedicine, which means all the bread and butter stuff, and often the minimum is sort of whatever Medicare covers, they'll cover. And then a lot of times it'll be more than that. And all the way to a full parity where they say, anything you can do by video, we'll cover it the same as we would cover in person. It doesn't mean that the patient all of a sudden has coverage for something that's not in their insurance plan, but if it's in their insurance plan, they can do it by video. That's common. And I also make this point, and I'll make it a little later too, but when you're contracting in a service, it's absolutely a best practice to have that service operate within your local EMR, if at all possible. To have that specialty care be noted, documented within your local EMR. It just adds to the integration. It makes it a higher quality service all around, rather than faxing reports back and forth, or because the patient really isn't. If you're contracting, the patient really isn't enrolled at another provider. They're enrolled at your clinic, and this provider who you're contracted with is your provider now. They need to document in your EMR. So that's a best practice for integrated primary care. And here's a slide that shows that in picture form. Okay, so this slide was coming, so I talked before I put it up. But anyway, you get the idea. So now let's talk a little about chronic care management. Chronic care management codes, these are a couple of years old now, so people are kind of getting the idea of what this means. But for those that are still a little unclear, it's basically a monthly code. You provide a set of services, a package of services, and there are specific patients who are eligible for these services, basically chronic disease patients with 2 or more comorbidities that are at risk for inpatient. And you enroll them according to a certain set of principles, like they have to know that they're being enrolled. You get consent, and you enroll them into a registry system of some kind using electronic management of a registry. They have enhanced access to care, 24/7 care, so that if a problem arises, they can call at any time and get advice about it. There's care planning. They're being treated according to a plan. It's proactive rather than reactive. It is registry-based, population health focused, proactive care based on or focused on a COPD population or a diabetes population, or some other chronic disease population, asthma. These are the big ones, and a number of services are involved. The primary one being that somebody on the care team, and it doesn't have to be a licensed provider, and it doesn't have to be directly supervised. So it's someone on the care team spends 20 minutes a month reviewing data, contacting the patient, doing stuff on the patient's behalf that is communicated and kept in the attention of the primary care provider, so that the patient's COPD, for example, is managed on an ongoing basis. And when physiological parameters are out of range, they get a phone call, or somebody follows up and does med reconciliation, or does the thing they need to do to keep the patient managed in a proactive way. So that's what CCM is about, and it pays on a monthly basis. It's about $50 plus or minus to do that. And so even though $50 is not a lot, you can manage dozens, hundreds of patients with a fairly small staff using this model. And so it does have financial benefits. And the reason I'm talking about it here is two reasons. One is that you can use telehealth types of equipment and procedures to do it, but even more importantly, there is a behavioral health version of this. It's a year newer. It just came out this last year. But the collaborative care management codes are a very similar thing. Instead of 20 minutes a month, it's 60 minutes a month, 70 in the first month, but 60 in subsequent months, of activity on the patient's behalf. And that could be direct care time with the patient, but it could also be reviewing cases. It could be collaborating, meeting with the primary care physician, meeting with a psychiatric consultant, or doing any of a number of things, administering scales. There are a number of practices that can go into that 60 minutes a month. It pays about $150 a month instead of $50. And it involves a specific specialist, that is a psychiatric consultant, could be a psychiatrist, could be a psych NP, somebody who manages mental health pharmacology. That person, here's an interesting thing. Let me see if it's on the same slide. That person, the psychiatric consultant, does not need to see the patient. So here's my fancy animation. Primary care physician and the patient. They bring in a psychiatric care manager. So this is the PCM. Doesn't have to be a licensed clinician, but it could be. Could be an LCSW, could be a licensed addictions counselor, anybody with some formal mental health training, but not necessarily a license. They work with the patient on behavioral activation, motivational interviewing. They do provide feedback to the PCP on how the patient's doing. They can administer these little standardized assessments, not a formal assessment, but a small PHQ-9 standardized kind of assessments that regarding how the patient is doing. They can provide additional therapy services if they're licensed to do therapy and credentialed to do therapy, and that's separately billable. But basically, they are the patient's primary contact around behavioral health issues, and they coordinate with the primary care doc. So this little team is providing care management for the behavioral health aspects of the patient's care. Now, in addition, and this is where collaborative care differs, there is a psychiatrist on board who gets information from that from that psychiatric care manager, reviews the chart, consults with the primary care doc, and provides treatment recommendations to the primary care doc. They don't ever have to see the patient. They can, but they don't have to follow the COCM, the collaborative care model. So because of that, that psychiatrist or psychiatric consultant can review lots of cases. They can tee them up and sit down with the psychiatric care manager and just go over case after case after case and make recommendations and do a much higher volume impact, a much higher volume of cases, allowing the primary care doc to actually write the prescription and the psychiatric care manager to follow up with response and side effects and hear from the patient how it's doing and how they're doing with that med, and provide supportive kind of wraparound services to ensure success and report that all back to the psychiatrist. And the psychiatrist can then iterate the treatment and say, okay, now I want you to double that one, or remove this one and let's add this adjunct medication instead. Can try different algorithms to work on that on the treatment, but they don't have to spend the direct care time with the patient. So that's the idea of collaborative care management. Also in the FQHC, RHC space, this is called behavioral health care management. It has a similar kind of a code that can be billed out of an FQHC or an RHC that has a different kind of billing mechanism. Like I said, the care manager doesn't necessarily have to be licensed, although they need to have some training. Indirect supervision is provided by the primary billing physician or PCP or NP, okay? So in other words, they don't have to be in the same room at the same time and all of that. They're basically just on the care team. Any separate services that the PCM, the psychiatric care manager, is licensed to provide can be provided and billed separately outside of this $150 a month collaborative care code. But the time also has to be provided outside of that 60 minutes a month as well. And they can be provided in person, by video. Don't always need to include the patient, so collaboratively with other clinicians about the patient's case or reviewing data from the patient is all counted. So it's a chronic care management model specifically for behavioral health care, and it is an outstanding new opportunity to use telehealth in primary care and to provide behavioral health care. This is just some codes and current payment rates, levels. This is just to let you know that yes, there are real dollars associated with this. I'm not making up these numbers. And as long as you know as long as you know which code to read, you can see what they're worth, and it's a very good it's a good reimbursement rate. Back of the napkin kind of figuring here, you can basically bill about twice what the program would cost to implement, which means you might break even if you're really good. So, and I just put these numbers in there again just to kind of get you thinking and think about a way of like the implement. So, as I mentioned, there's a slightly different way to build this in an FQHC or an RHC setting. They're G codes, G0511, G0512, but they're basically the same type of thing. The 511 is the chronic care management, general care management code. The 512 is the behavioral health care management, the one that we've just now been talking about within the FQHC, RHC setting. They have the same requirements for services, but because of the different billing mechanisms of these types of facilities, they have a different code to bill. Okay, so that's the whole chronic care management or care management kind of approach. I also want to say just a little bit more about echo groups. I brought this up before. The idea here is, remember, a force multiplier. And there are echo groups. Echo groups has become a kind of a terminology for lots of different sorts of force multiplying types of efforts. But the idea is that it's like a case conference on steroids. It's a case conference with a specific aim. It's structured. People come with cases to present. A specialist reviews them and makes recommendations. And over time, the primary care provider or the echo participant becomes a mini specialist, improves their skill set in managing these cases. And often in an echo group, or sometimes I should say in an echo group, really complex patients can be referred up to the specialist. And so the specialist can see the real top complexity cases. But in general, the primary care doc or the participant ends up seeing more and more complex patients on their own and being able to manage complex cases on their own. What happens in these groups, remarkably, is that, as expected, PCPs develop better specialty skills and keep more cases. The specialist sees only more complex cases, and both groups actually start to see a higher average acuity of patients in this particular with this particular condition. One of the other ideas is that one of the other hopes is that these primary care docs who become sort of mini specialists can start to function as the specialist on their primary care team or in their locale, in their region, at their clinic, whatever. They can become the endocrinology person or the mental health person or the pain management person within their local context, and then have access to specialty training or specialized supervision to develop those skills. So with a combination of interest and training, they can make those cases, those skill sets and services more available in local areas. This is a picture of an echo group. This is how it gets implemented, actualized in video, where you've got the central echo project. In fact, I think that's the founder, Sanjay Gupta, there behind the laptop with the tie. And then these are remote sites. He's got some local clinicians sitting in around his table, but then there are also clinicians sitting in across the country, and they're talking about various cases and present them. So that's the echo model. Another model, and I'm going to throw out a couple of models, a couple of things just to kind of get you thinking. This is a very impressive group in northeastern Minnesota that I just happened to like really a lot because they saw a problem and they pulled some resources together and they made this happen. The Arrowhead Health Alliance is a group of community mental health centers in northeastern Minnesota in 5 counties up there. And what they did was The state of Minnesota had a video network. It's powered by video, the video conferencing software. It's a direct competitor to Zoom and VC, just like what we're doing now. But the state has a video platform, and these community mental health centers banded together. They formed an organization. They all got seats on the state's video conferencing platform, and they have various agreements to buy and sell services and see patients, and they've created kind of an online market for their services among groups, so they can basically buy local first, use local services first. And local doesn't have to be in this town. These counties, you can't tell with this map, but these counties are extremely rural, and there's huge swaths of national park and forest and uninhabited regions, areas, and so providers or patients would have to travel quite a long distance to find somebody if they weren't in the local community. And so this organization now has kind of created a virtual highway that they can transport services back and forth among all of their locations. And it has been slow to get started. I think they would agree. It does, you don't just build it and they suddenly show up, come walking out of your cornfield into your clinic. But they do. But they are very happy with what they've been able to show so far. And as you can see there, the numbers are not insignificant. With 300 accounts, 4,000 users across the state, and considering other expansion programs as well. So that's an impressive group, and it's another sort of model that is not a direct service model, but is more of a meta model, a collaboration across a geographic region kind of a model. One other model or example I'll throw out, because it comes up a fair bit, is getting emergency room evaluations, and that can also be contracted. This is a particular organization in Iowa that is providing mental health emergency evaluations in emergency rooms across Iowa, in hospital emergency departments across Iowa. They do 12,000. There are 300 evaluations done at Skiff Medical Center. That's one site. But ITP, Integrated Telehealth Partners in Iowa, is the psych provider. And they have a team of psychiatrists that does these evaluations remotely by video. But then what ITP does that's different, and this is why I call them out here, is that they also manage a placement database, because inpatient beds, like many places, in Iowa, like many places, are scarce. And so they manage a database of inpatient beds, and they're continually calling inpatient facilities and asking for their census, their bed count, what's available. And they not only evaluate the patient in the hospital emergency department, but they then do the disposition and do the placement and say, okay, there's a bed, it's 60 miles northwest in such and such a town, we can arrange transport, ambulance will be there. And so it's a one-stop package, because the primary problem with emergency department evaluations is, okay, now you've told me this patient needs to be inpatient, where's a bed? And that was the choke point. So ITP really took that problem on and learned to manage that, and became a great resource because of it. So these are just a couple more kind of thoughts and ideas, as you might hear in any healthcare presentation. Clinical processes, of course, are going to drive what you need and what you develop. But as I said, the kind of core pieces that you need: sustainable revenue models, motivated clinicians and partners, and a designated or an identified need, and some dedicated staff. Obviously, these are things that probably don't need to be reminded about. Recognize too that in the technological world, solid broadband is the water that everything floats on. You can have a beautiful boat, but if you don't have any water to put it in, it's not going to work. And broadband is that water. So a good broadband connection is absolutely the number one issue in deploying these technologies. And don't forget the knowledgeable partners, and that's where we come in at the telehealth resource centers. We are available to consult and are happy to do that. Okay, These slides are available. This recording is available. I'm going to take a few minutes for Q&A. I'm going to open up the Q&A window here and see what we've got. Oh, my goodness. Okay. First one, what should proponents of telehealth say to physicians who push back against this form of delivery of care on the basis that it creates unfair competition? Oh, that's a big question. Unfair competition. It's sort of like, you know, yeah, I don't know a good way to say that. It's unfair in the sense that, yeah, now a telehealth provider can deploy their services anywhere, whereas the bricks and mortar provider is limited to their street address. That's a bad thing for the bricks and mortar provider, but I just don't see that going away. I don't see that changing. I don't know of a nice way to say that. It is a big barrier, though. Incumbent providers are suspicious of telehealth because the healthcare world, believe it or not, if you don't know this, the healthcare world is rife with competition and patient stealing, and this is the #1 fear of a lot of providers. So if you're deploying a service, you need to be aware of that and recognize that if it's your providers that are afraid of their patients being stolen, if you're a health system or whatnot, make sure that you take that seriously. Next one, how do clinics, et cetera, deal with the Cures Act regulation that requires all servicing and billing providers to be enrolled and known to the system for Medicaid? The main thing there, if you're in Medicaid, you can bill as an independent provider, as a legal entity, but you can also be an employee or a contractor of a billing entity. And so either of those is fine. If you are, an employee of a community mental health center and that community mental health center bills, then that's the known entity, and they just need to credential you as a provider. If you are billing as yourself, as your own private practice, or as whatever entity is billing, that's the entity that needs to be known to Medicaid. So yes, they need to be registered, but with contracting arrangements, you're trying to bring that legal entity into bring the power to bill within the clinic, and then that clinic is a known legal entity to Medicaid, at least if you take Medicaid. If you don't take Medicaid, there's no way around that. You're going to have to get on that if you're going to bill Medicaid for those services. I wonder if there might be a little more to your question that I'm not getting, and feel free to follow up with me if there is, and we can go into the details further. Next one, what would be the place of service if we have a psychiatrist at our main location and they provide telemedicine to clients at our branch office in order to save driving time? Would you call that the office, and would we use the GT modifier? That depends a little bit on your state. It depends a lot on your state and your payer. Unfortunately, the GT modifier specifically, each payer, right now, we're in a little bit of a weird transition. Each payer is going to decide whether they want you to add the GT modifier or not. But what I can say in general is that the patient's location is the location of service as far as a street address. If there's a geographic location of service, it is the patient's location. But if the service is being provided by video, then the place of service code is 02. I mean, that's the technically correct answer right now. Now, some payers are going to say, hey, bill it this way for us until we get our systems updated, or we're going to bill it this way until January 1, 2019, or whatever. They may have specific clarifications there, but the place of service code for any virtual encounter is 02. The geographic location of service is the patient's address. Our remote site and originating site the same. This probably came up when I was talking about the contracting arrangement. It's a weird question. Geographically, of course, they're not, but legally, yes. Legally, it becomes, when you're contracting for a service and you're billing for the professional as well as the originating site, legally, the originating and distant site are the same site. And that's kind of the crux of the issue. But don't be afraid to bill for both sides if you are legally entitled to bill for both sides. I mean, if you're contracted with the provider and you're the one presenting the patient and it's your patient in your clinic, then you are legally entitled to bill both sides of that encounter if that's the way it's reimbursed. Now, if you're a clinic that bills with a PPS rate or an all-inclusive rate or whatever, then it's different. But if telemedicine is being billed as an originating site and a distant site, and you own both sites or are contracted, then you can be both sites. I'm not sure if I missed this, but does the first office visit for mental health service have to be in the office? There's a state variation there. When that comes up, it's usually because there's a state rule about prescribing to patients that you have not seen in person. And so what they'll say is you can't prescribe unless you've seen the patient in person, and then organizations will develop a policy that says, okay, we have to see everybody in person the first time. Not all states do that. In fact, a small number of states do that, require that. But it usually has to do with prescribing and no other particular limitation. Also, by the way, at the federal level with the Ryan-Haight Act, that will cover your Ryan-Haight Act, because the Ryan-Haight Act excludes prescribing controlled substances if you haven't seen the patient. Once you've seen the patient, it doesn't apply. You can then prescribe as you would normally. CCM primarily utilized by Medicare or our commercial payers reimbursing. Commercial is reimbursing for that. It's growing. Sometimes those type of services get rolled into other sorts of quality measures, but the CCM codes are quite popular and growing in, I shouldn't say quite, they're growing in popularity rapidly, so they are not a new thing. Are there a growing number of companies providing telemedicine platforms? Some are video only, some have EMRs, some are add-on. Yes, true. That is all true. I'm not sure what the question is, but yes, you can do video in a separate platform. You can do it within your EMR. Usually it's a financial question of what's going to be more expensive to implement, or what sort of support does your organization provide, whether it's through the EMR or outside of it. Any advice? Oh, any advice on selecting a platform? Like I say, there is a site, Telebehavioral Health Comparisons.com. It's a big site name. Telebehavioral Health Comparisons.com. It might be Telemental Health Comparisons. But anyway, follow up if you don't find it. But the proprietor of that site does a good job of reviewing lots of platforms and kind of telling you which ones even are in the same class with each other. And that can be a start at least. And if you want more specific advice, follow up with your local telehealth resource center and we can give you more specific advice. Next one, if Medicare does not pay for a teleconsult in a CAW, can the CAW provider pay the physician specialist directly for a consult and place the expense in the cost report? Oh my goodness, this is an SAT question. I suspect not, but you probably want to follow up and work out details. What you're looking for, I think, is a workaround, and there are legitimate workarounds, I think, for your situation, depending a little bit on what exactly is the consult. But I think there might be some specific workarounds that we can look at. But if the problem is that the patient is sitting in a non-rural originating site and so are just not eligible for Medicare in that space, I don't think there's a good way around that. That's one you just can't get around. That's the big kind of poke in the eye from Medicare. The patient location is going to put the kibosh on just about anything there with regard to Medicare. So if that's the case, sorry about that. Next, yes, so I work for Medicaid. 21st Century Cures Act requires all providers to be known to the system. It's complicating. Oh, okay. What I think the 21st Century Cures Act, the issue there is about rendering providers. And yes, rendering providers need to be known to the system. So providers that don't normally take Medicaid have to be known to Medicaid. This is probably a more complicated question than we need to get into. There is also a lot of debate about this right now. At what level does that provider need to be known? Because there are providers working out of home, contracting with FQHCs or community mental health centers or hospitals or clinics. And the issue is, does their home address then need to become a site that's listed in a registry? And it doesn't make any sense logically that their home would become a site just because that's their office, where their office is. And it's being debated. I know in my region it's being debated quite extensively. So I'm going to have to punt on that one and say, follow up with me directly if you're interested in this question, because I'm actually involved in conversations about it right now, or your local TRC, and hopefully we can get a better answer than what I just said. The clinic-to-clinic scenario, you're saying O2 can be used even though the patient isn't actually at home. O2 is not at home. O2 just means via telemedicine. It means within the telemedicine space. So yes, clinic to clinic, office to clinic, any telemedicine encounter, the place of service, according to Medicare and most payers now, is O2. So, so yeah, it doesn't actually refer to the home. Can a provider admit and discharge a patient in the hospital via telehealth? That is going to be state specific and facility specific. In general, the organizations that have tried to do something like that have had problems doing it for a number of reasons. It's not just a simple yes or no answer. Because usually, I mean, although you can provide a consult for an inpatient, for an initial inpatient by video, Medicare pays for that, and most payers do. Usually the inpatient evaluation, the initial admission visit, is by policy an in-person visit. It's defined as such, and that's usually the problem. So I can't just say yes or no, but I can say that in my experience, most of the time the answer turns out to be no. So follow up if you have more details, or you want to work that one a little more and see if there's a way to manage it that is legitimate. Next, can you recommend an app for smartphones that handles paperwork, signatures, requirements, etc. for telehealth, mental health services? Ooh, I wish I could, but I would refer you again to telebehavioralhealthcomparisons.com. And if you can't, again, if I'm saying that website wrong, follow up with me and I'll make sure. I think that's the kind of thing that Jay is a counselor who runs that site. He would know this, and he'd be a resource there. You can also get a hold of him through Jay Ostrowski through the Mid-Atlantic Telehealth Resource Center, matrc.org. So if you leave them a message, they will put you in touch with Jay Ostrowski, and he can answer that question for you. Can you please give the software platform websites again? Oh, the platforms that I'm just throwing these out because they tend to be the big 3 or 4. Zoom.us is one. VSEE.com is popular. VidYo.com is another very widely used in healthcare platform. And then you'll find a fair number who are using Microsoft's platform, Office 365 and Link for Business. Microsoft will assent to, or they give you the terms basically of a BAA, of HIPAA compliance if you're using their platform. I hesitate to say that any platform is HIPAA compliant because it all depends on how you use it, but you can use Link for Business in a HIPAA compliant way. In the same way, Google Docs and Google Office, G Suite, you can use in a HIPAA compliant way, and Google will support that. So those 2 platforms plus the 3 that I mentioned are probably the top 5 in the healthcare space. I'm probably forgetting 1 or more good ones, but the place to go is ttac.org. That's Telehealth Technology Assessment Center, TTAC. It might be TTAC online, but if you just look for TTAC and telehealth, or go to the telehealthresourcecenters.org national website, you can find a link to TTAC and get in touch with them, and they will let you know. there are a number of services that are built on top of various video technology platforms. So, for example, the person who says Bluestream Health has been very successful for organizations, very affordable. Yeah, Bluestream is probably built on top of a a video conferencing technology, and they're providing various services on top of that. And so there would be dozens, literally dozens, of companies that are offering sort of enhanced video conferencing for health. And I don't know all the folks that have a longer list, but Telebehavioral Health Comparisons would be the site that would be come closest to exploring all of those. Also, I might say that on the VC site, vsee.com, they do their take on comparing the various video platforms, and it's very interesting to hear what they think are the pros and cons of each video platform. So that's worth a read. I don't recommend one site one platform more than another. We have to be careful about that. But it is interesting information, and those are people who know a lot about video. So take a look at that. All right, we are blasting through that hour, and we've thank you all for the Q&A. This has been fantastic. Thank you for your attention. I hope this was helpful. Do feel free to follow up with me directly or with telehealthresourcecenters.org or gptrack.org, and we can get other questions answered if you have still more. And with that, I think we will wrap it up.